you all know, thalassemia is a commonest single gene disorder. And most of us, those who work in the field of genetic and fetal diagnosis, our work is prevention. So we keep preventing the prevention of we keep in the prevention of Down syndrome, prevention of thalassemia, congenital malformations, stillbirth, prevention of genetic disorders through the carrier diagnosis. And today I'll be speaking about the prevention of thalassemia by the carrier screening and the prenatal diagnosis. I'll be discussing about the basics of thalassemia, screening for thalassemia, few cases, and touch upon the government initiatives for the sickle cell anemia, which was launched in 2023. So this is the spectrum of thalassemia and hemoglobinopathy in our prenatal genetic clinic. 1/4 of our cases are referred for prenatal diagnosis for thalassemia major or intermediate. And some of them would be beta thalassemia trait, one partner, and the other partner is normal. Even one partner with hemoglobin D Punjab and beta thalassemia trait, both couple hemoglobin E trait, then the children with hemoglobin E beta thalassemia, children with sickle cell anemia, and the alpha thalassemia carrier status like hemoglobin Q India, hemoglobin GA Merit. So you can see here, 1/4 requires prenatal diagnosis, and rest all, 3/4, is related to the genetic counseling. So it's very, very important that we understand all other hemoglobinopathies other than beta thalassemia trait, where the genetic counseling is also required. So let's begin with the first case. This is a case with the pallor was noted by the parents at around 4 months of age, and the child had the hemoglobin of 5.6 gram with microcytosis, peripheral smear suggested dimorphic anemia, and when the HPLC was done, it suggested at 4 months the hemoglobin F is 100%, and this clinched the diagnosis of thalassemia major. Transfusion was started at around 1 year of age, but unfortunately, the child succumbed to the illness. And this is the commonest presentation to us, that now the mother is pregnant and they want a prenatal diagnosis in view of the previous child affected with the thalassemia major. Then the another common presentation is the previous child affected with E beta thalassemia. So where one couple is E trait and the other partner is a beta thalassemia. So they have a 25% risk for E beta thalassemia. This child was also referred as a case of anemia and apparently all right till 6 months of age. And at the time of vaccination, the pediatrician noticed that the child is significantly pale and with associated hepatosplenomegaly, severe anemia, and the HPLC suggested that the hemoglobin F is raised, E plus A2 is 83%, and then the diagnosis of E beta thalassemia was made clinically and followed by the mutation analysis, which confirmed the diagnosis. So this child is on the hydroxyurea on now and doing well. So thalassemia is a group of inherited disorders of ineffective erythropoiesis, which is autosomal recessive inheritance, meaning thereby where the parents are silent carriers and the children have a risk of about 25% in the pregnancy. History of thalassemia is very interesting. In 1925, in a meeting of American Pediatric Society, Cooley and Lee, they reported the children of Mediterranean extraction with anemia, splenomegaly, and the peculiar changes in the bones. And in India, in 1938, just 13 years after that, Mukherjee published the first recorded case of the thalassemia in east side of the Suez. And this case was observed by Dr. M. Bose of the Campbell Medical School and Hospital in Calcutta in a Hindu boy which was aged 30 months. So the first case appeared in 1938, and this case established that the disease can be found in the children of non-Mediterranean parentage as well, and thus justified the scrapping of the term Mediterranean disease. And subsequently in 1939, treated in India by Coelho in 2 Muslim sisters from Bombay, by Napier and Das Gupta from Kolkata, and by Patel and Bhende from Bombay in a boy of 5 years. Cases were recognized and reported from all other parts of India, including Punjab, Kolkata. So that means that this was a pan-India situation. So the first case of the beta thalassemia, E beta thalassemia, was reported by Chatterjee and that of the beta thalassemia plus sickle cell disease by Nayak and colleagues. And subsequently, other hemoglobin variants were reported like C, D, F, G, H, hemoglobin Q India. Hemoglobin S, D, and E, they were observed to be quite common. Hemoglobin S has been found mostly in the tribal communities. Hemoglobin D Punjab in Gujaratis and Punjabis, and hemoglobin E in Bengalis, Assamese, and Nepalese. So the global burden of thalassemia, that there are about 7% of the carriers of the thalassemia, and this is prevalent in the Mediterranean region, Middle East, Central Asia, Indian subcontinent, and Africa. And the highest incidence has been reported as high as 14% in Cyprus and 12% Sardinia and also in Southeast Asia. And this is related to the selective pressure from the malaria, where the heterozygotes would have a survival advantage. And this is the basis that it is reported that this is higher in these areas. The burden of thalassemia in India, this is of course the commonest single gene disorder for us. And there is 10,000 babies of thalassemia born every year. And it is reported that the 10% of the total world thalassemics are born in India every year. And sad to say, we are cited as a thalassemia capital. Then prevalence of the carrier status of beta thalassemia is about 3 to 4%. Alpha thalassemia is about 13%. Delta beta thalassemia and hereditary persistence of fetal hemoglobin, they are less frequent, but the carrier status for the S carriers like 5 to 40%, E carriers 3%, 64%, D Punjab 3 to 4%. So what is hemoglobinopathy? Hemoglobinopathy is basically divided into the two general types, the thalassemias and the hemoglobin structural variants. In the thalassemias, there is a disorder of the decreased beta globin gene production, and in the hemoglobin structural variant, there is a defect in the structure. And a combination of two is also possible, like E beta thalassemia, S beta thalassemia. So we have thalassemia like alpha thalassemia, beta thalassemia, but we also have a combination of structural variant like E beta thalassemia, S beta thalassemia. So hemoglobinopathies, thalassemia syndrome, and the variant hemoglobins. And this is the southern part of the Europe, that is the Mediterranean area between the Africa and our country. This is the Mediterranean region where the thalassemia is very common. And of course, in Southeast Asia, Africa also, this is common. So what is the structure of the normal hemoglobin? So this is important to understand the pathophysiology of the beta thalassemia or the alpha thalassemia. Hemoglobin is a tetramer of the globin chains, a pair of alpha-like and a pair of beta-like genes. Adult hemoglobin is alpha-2, beta-2, and fetal hemoglobin is alpha-2, gamma-2, and A2 is alpha-2, delta-2. So there is a difference in the hemoglobin in the fetus and the adult. In the first 8 weeks of life, there is the embryonic hemoglobins, that is the Gower 1, Gower 2, and Portland 1. By 12th week, the hemoglobin F starts forming, and hemoglobin F persists till about the 6 months post-birth. Adult hemoglobin starts forming in the 16 weeks of the pregnancy, and it is totally replacing the hemoglobin F after birth, usually 6 to 7 months after the birth. In the normal adults, we have hemoglobin A of 96 to 98%, A2 2 to 3%, and hemoglobin F less than 1%. Two common types of thalassemia, that is the alpha thalassemia and beta thalassemia, and the clinical types, which are the significant enough to warrant the blood transfusion, and the one which is the burden for the country or for any other country, that is the thalassemia major and thalassemia intermedia. In thalassemia major, based upon the clinical severity, in the major, usually 3 to 4 weekly blood transfusion is needed. In thalassemia intermedia, the blood transfusion may be needed about 3 to 4 months. So the difference lies in the severity. In alpha thalassemia, there is decreased production of the alpha globin chain. But unlike beta thalassemia, alpha thalassemia produces the intrauterine disease, because alpha thalassemia, alpha gene is alpha 2 gamma 2, and so that's why the formation of the fetal hemoglobin. So it is produced, it also produces the intrauterine disease. But in beta thalassemia, the disease usually produced after 6 months, when the hemoglobin F is diminishing and the hemoglobin A should have started forming. So because of the beta thalassemia, hemoglobin A is not being formed. So the beta thalassemia manifests, the symptoms starts around 6 to 7 months post-birth. Beta thalassemia, they are an autosomal recessive disorder, and the globin structure is normal, but the rate of production is reduced. And the clinical spectrum of beta thalassemia is a silent carrier state. This is the mildest form, beta thalassemia trait, beta thalassemia intermedia, or thalassemia major. Similarly, there is a spectrum for the alpha thalassemia, but in contrast to the beta thalassemia, where there are just 2 alleles, in alpha thalassemia, there are 4 alleles. So a normal person will have two alleles on both the genes, and a silent carrier could have either one gene defective, or a minor could have 2 gene defective. There could be 2 types of minor. They could be either trans form, or they could be in the cis form. So in the trans form, the both different forms of the alleles have the variant, whereas in the cis form, both the defective alleles are on the same chromosome. Hemoglobin H is formed where there are three defective alpha globin genes, and in the hydrops fetalis, which results due to the hemoglobin BARTs, all the 4 alpha globin genes are knocked out. So here it is the difference. This is in the cis form, and this is in the trans form. And this is the form which causes the hydrops fetalis. This is the alpha when the both gene on the same allele are missing, or the defective. So in hemoglobin H disease, there are 3 alpha genes which are defective, and hemoglobin BART, 4 alpha globin genes are defective. These are the different structural variant for the alpha chain, that is the hemoglobin Q India, hemoglobin J Meerut, because this was identified in 2 sisters from Meerut, India, and that's why this is named hemoglobin J Meerut, then J Paris. The structural variant which we commonly come across in India, that is the D Punjab, hemoglobin, sickle cell hemoglobin, hemoglobin E, common in the people from the northeast background, hemoglobin S in the tribal population, D Punjab, because I work mainly in Delhi. So the D Punjab, we get lots of cases with the hemoglobin D Punjab carrier status. So why alpha thalassemia or beta thalassemia would happen? So the pathophysiology is that it is because of the imbalance. So whenever one of the gene is absent, the other gene forms in the excess, and this excess free globin gene will form a reactive oxygen species and triggers the cascade of events that lead to the hemolysis and the ineffective erythropoiesis. So this is a couple with one couple with the delta beta thalassemia, and the other is the beta thal trait. And this child was on the regular hypertransfusion at AIIMS Delhi, and they had come to us that because the husband was a beta thalassemia trait, and you see the HPLC of wife here, her A2 is perfectly all right, but her F is high, and this is the finding clinically. This is the delta beta thalassemia trait, and so we did perform the fetal testing, and the CVS was done and the fetus was not affected. Here, both the couple, husband and wife, is thalassemia trait. We see the A2, which is more than 3.5%, that is around 6.8%. And we also look at the CBC, where there is a slight anemia as well. And the RBC count is raised, and MCV is microcytosis, that is 60.4. So it should be usually less than 80 in cases of the carriers. So both the couple were thalassemia trait. So we performed the genetic counseling, and we suggested that the risk of thalassemia major is 25% because this is a autosomal recessive condition, and CVS was advised at 11 to 12 weeks after the NT scan. And before that, we performed the mutation analysis of the beta thalassemia. So this is how in every pregnancy, there is a 25% risk of thalassemia major, 50% risk of the children being thalassemia trait, and 25% being entirely normal. So we did the CVS. Father has this mutation, frameshift 4142. Mother, we initially performed the 5 common mutation, which was normal. Then we found by sequencing, this was identified. But the fetus was positive for the maternal mutation. And here it becomes very, very important to know that because this is a maternal mutation, so we must check the maternal cell contamination, and this was not there. So the fetus is a carrier, not affected, and the pregnancy was continued. So the common mutation, there are 5 common mutations in India, that is IVS15G2C, IVS11G2T, frameshift 89619 base pair deletion, frameshift 4142. Rare mutations are about 8% and maybe 2% uncharacterized. So we perform CVS at around 11 to 12 weeks, and for CVS procedure, we require about 35 to 40 milligram, and we quote the risk of procedure-related risk of abortion of about 0.2 to 2%. So this is how we perform. We give a local anesthesia, and through a 18 gauge needle, we enter the placenta. You can see here the needle entering into the placenta, and back and forth motions, and we suck some amount of the chorionic villi, and that chorionic villi is sampled for, is tested for the parental identified mutation. You can see the back and forth motions. So what are the most important steps for the diagnosis? One has to be very certain that both parents are carriers, and sometimes we have seen the cases where the one of the the CVS has been performed, but one of the HPLC reports was wrong. So be very careful in analyzing the HPLC reports. Whenever there is doubt, it's better to repeat the HPLC. And when one of the partner is a carrier, one must exclude that the other partner is not a silent carrier. And best thing is that one must do a beta globin gene sequencing in the partner who is normal. And also, to give a good prenatal diagnosis, we need to know which combination of alleles is significant, that whether you need the invasive testing or the genetic counseling will be sufficient. So there are few combinations of the HPLC reports which will need to the prenatal diagnosis by the CVS. That is both the couple beta thalassemia trait, one couple thal, and the other partner is hemoglobin S trait, a combination of beta thal and hemoglobin E, both couple hemoglobin S, and hemoglobin S in any combination. So for that matter, hemoglobin S is with whether beta thal E, you always require the CVS. But in some of the cases, you don't require the CVS, but you do require the molecular confirmation for these. Like suppose one partner is beta thalassemia and the other partner is D Punjab. So the partner who is D Punjab, you must do the sequencing to identify that whether there is some hidden beta thalassemia in that person. So whenever there is one partner with beta thalassemia, the molecular confirmation is a must for the second partner. So these are the cases which are clinically silent abnormal hemoglobin, like both couple hemoglobin E trait. So there will be no need of prenatal testing. Both couple hereditary persistent, both couple hemoglobin D Punjab trait. But all these we confirm by the molecular testing, because sometimes hemoglobin D Punjab and E beta thalassemia will be coexisting. So we don't say only on the basis of HPLC report. We always do the beta globin gene sequencing to give the final recommendation that whether you need a CVS or whether the genetic counseling is sufficient. Like one combination of J Merit and beta thalassemia and alpha thalassemia in the trans. So they don't require the prenatal testing. Then the prenatal testing, that is the CVS, both couple beta thal trait, both couple delta beta, E trait plus beta thal, delta beta plus thalassemia, then both HBS plus beta thal. HBS in any combination would require prenatal if we want to remember, and then the alpha thalassemia in the cis form, because they are the one which will lead to the hydrops fetalis. This is a case which was referred to us long ago at 18 weeks. And by that time, the diagnosis of E beta thalassemia was not there. And this child was already 7 to 8 years of age, and her hemoglobin was 7 to 8%. She was not doing good quality life, but of course, she was not on any transfusion also. So we did the HPLC of the couple, and we found that the mother is E trait, and the baby and the father is beta thalassemia trait, and the HPLC of the baby showed E beta thalassemia. And because the F is raised, so this can be thalassemia intermedia. And A2 plus E, you can see here, is 68.6. And in the mother, it is 26. So she is a carrier, and the baby has got E beta thalassemia. So the risk of E beta thalassemia in this ongoing pregnancy was 25%. Although the pregnancy was 18 weeks, but we resorted to do the placental biopsy, because for molecular testing, the CVS samples are better, and the fetus was hemoglobin E trait, so the pregnancy was continued. So counseling, when one partner carries the beta thal and the other is hemoglobin E, So the child may inherit beta thalassemia from one and hemoglobin E from the other. And this risk is, again, like here, we can see here out of the 4 possibilities, 1 in 4 is the possibility of E beta thalassemia in this situation. So E beta thalassemia, they clinically behave as thal major or intermediate. Like in this case, this was behaving as intermediate. She was not on transfusion. And the usual presentation is anemia, splenomegaly, and they can be symptomatic and transfusion dependent. And they require 40% of these patients will clinically improve with hydroxyurea. So this girl, after we made the diagnosis of hemoglobin E beta thalassemia, she was put on hydroxyurea and she is doing well. This is a very common presentation to us when both couple is hemoglobin E heterozygous, and this couple conceived with great difficulty by the IVF conception, and they were quite stressed when they were referred to us at 10 weeks. They were told that both the babies and now you require the CVS and all because both the couple is hemoglobin E heterozygous. This couple was from Bengal, and you can see here the A2 is raised, and this signifies whenever the A2 is more than 5%, this could be either E or it could be D Iran. So by looking at the background, if they are from the Northeast or the Bengal, they can be most likely they are the E heterozygous. So whenever we have any HPLC report, we confirm this by the molecular testing. So we did the molecular testing and that confirmed that both the husband and wife are heterozygous for hemoglobin E. So how to counsel after the genetic testing? That homozygous hemoglobin E, which they have a risk of about 25%, they will have either mild anemia or no anemia. So the prenatal diagnosis is not justified by the hemoglobin E homozygous. So you can see here one of the patients, hemoglobin, which is hemoglobin E homozygous, his hemoglobin is about 14.5. And we see here A2 is around 83 points. So this person is a hemoglobin E homozygous, and still there is no problem. So hemoglobin E homozygous is clinically silent or mild anemia. So no prenatal testing would be required here. And this is a very, very common genetic counseling referral. So one must remember that one should not do the CVS in these situations. So hemoglobin E is clinically silent. And this is caused by mutation of the 26th amino acid of the beta globin gene. And this mutation is very frequent. Frequency of hemoglobin E approaches 60% in the northeastern side, and there could be hemoglobin E trait or hemoglobin homozygous, but they are clinically silent. Then in Delhi and around Delhi, one couple with D Punjab and beta thalassemia trait. So the A2 is of course in beta thalassemia, A2 will be high. And in the D Punjab, this is a heterozygous form. So whenever we have this kind of hemoglobin D Punjab, we do the beta globin gene sequencing for this person to identify that whether that person is, because here you can see that there is microcytosis as well. So we already had a doubt, and we did perform the beta globin gene sequencing, but thankfully he had only hemoglobin D Punjab. So again, the risk of hemoglobin D Punjab and beta thalassemia both is about 25%. So the risk is 25%. But what do we tell them? We tell them that there is no particular problem for this couple because this combination of D Punjab after molecular confirmation, this combination cannot cause an inherited anemia in their children. So no prenatal testing would be required. In this couple, they were very late to come to us. This was about 26 weeks, and they were studying in JNU here, and this was a couple from Africa, and HPLC was suggestive of hemoglobin S trait. So the risk of sickle cell disease is 25% because this being again a autosomal recessive condition, and we performed amniocentesis here, but unfortunately the fetus was homozygous for the hemoglobin S mutation. Then we also have few reports of the pre-implantation genetic testing from India. This is a paper in one of the centers where I used to work earlier. And this is a pre-implantation genetic testing in a thalassemia carrier couple, a boon in the assisted reproductive technology. Then also people have utilized the HLA matching with the PGT-M, PGT-A. And this case, again, in an Indian paper, this has been published. And this is in 2019. Earlier, this couple had failed, thalassemia. They had one PGT earlier also, and 20 embryos were there. And out of the 20, only one was thalassemia minor, but there was no HLA matching. So this couple refused. But in the next cycle, they had the first child, they published PGTM, PGTA, and this baby was HLA matched, severe child for the previous child. So the consensus guideline which we feel after working in this field, that so universal carrier screening in the pregnancy or the preconception, we have started doing for all women, those who come for whatever reason, even if they have come for prevention of Down syndrome, prevent for ultrasound also, if they have come to us, we would do the carrier screening for each every pregnant woman by the CBC peripheral smear and the HPLC. And if there is a, in government cases, if there is lack of fund, then we can prioritize these women by the microcytosis, and do only if the MCV is less than 80 or MCH is less than 27. But it's much easier to do the HPLC. And whenever the A2 is more than 3.5%, one must screen the partner, and prenatal diagnosis should be done by in both the thalassemia trait, beta thal or E plus S, both S or S in any combination. And mutation study for 5 common mutations should always be performed prior to doing the prenatal testing. Then we see that there is, because this is such a major public health issue, that government has also realized that, the screening for thalassemia major, that should be done, because it is required about 2 million units of the packed red cells, which one can understand that, how much, expensive this would be. And so the government has launched this thalassemia and hemoglobinopathy in 12th 5-year plan in 2016 by the Ministry of Health under National Health Mission. But later on, they realized that as per census of 2011, the Ministry of the Tribal Affairs, they came across that India has 8.6% of the tribal population, and which is 67.8 million across the Indian states. And Ministry of Health Welfare Tribal Health Expert Committee reported that sickle cell disease is one of the 10 special problems in the tribal health. And that's why this mission 2023, this started last year only, and they have a mission and they have a vision. So the mission is to improve the care of the sickle cell disease. They have not included thalassemia. Thalassemia was in the 2016 healthcare plan, but now they have only included sickle cell disease patients for the better future and to lower the prevalence of the disease through the multi-faced coordinated approach towards the screening and awareness. And their vision is to eliminate the sickle cell disease before 2047. And how they are planning to screen entire population from 0 to a big massive effort by the government, 0 to 18 years of age. And the mission aims to cover 7 crore people. And the initial focus is 17 states with the higher prevalence of the sickle cell disease, including Gujarat, Maharashtra, Madhya Pradesh, Jharkhand. So all those with the highest tribal population. And this mission is based upon the 3 pillars, that is the health promotion, that is the awareness. Then the prevention is by the universal screening and early detection and holistic management. So that's how this same thing can be applied to the thalassemia control or thalassemia prevention, that we can do the universal screening awareness. And because I have realized that the awareness has been by the national prevention programs. One can see here the outcome of the national prevention program in Sardinia. Sardinia was one of the highest thalassemia incidents. We can see here in 1975, the 110 births per year, and in about 35 years they have reduced to about almost 10 births per year, and that is a significant achievement. And how they got this level, they educated their school going children, those the school and college going children, that the about the carrier prevention by the thalassemia testing. And they didn't say that the carrier should not marry each other. They just said that you go ahead with the carrier testing, and if both of you are carrier, then the prenatal testing should be done. And this is the way forward, that the carrier screening, and it should be done in the public awareness should be done, and that is mostly possible through the school and college going children, because they are the most receptive. Because of their learning phase, they are eager to learn, and they will get the testing done. And once they are educated, so they will not discriminate the other people. Sometimes we realize that a person who is a beta thalassemia trait or hemoglobin D Punjab trait, the people start discriminating that person is some problem. But when we educate the young children, they will realize that the carriers are healthy people, they do not have the disease. And this message needs to go to the public. And unless it reaches the public, the mass prevention which we aim at, that the thalassemia should be prevented almost as like the Sardinia did it. So the carrier screening, genetic counseling, prenatal diagnosis is the best strategy for the prevention. And the correct identification of the heterozygous mutation identification is a must for the prenatal diagnosis. Knowledge of when to do CVS is essential for correct prenatal diagnosis. PGT-M is available. NIPT for thalassemia has started in few countries, and maybe this will be a reality. So we don't need to do CVS. And then maybe in the future. And best way to prevent is to the public awareness by educating them. So thank you, everyone. So Dr. Ekta. Yeah.
Thanks. Thank you, madam, for your awesome talk. You made it easy and to understand, really interesting. Carrier screening and prenatal diagnosis for thalassemia is the need of the hour. And your enthusiasm for the topic was contagious, and I believe everyone is left feeling inspired and excited to learn more. Thank you so much again, madam. Before we begin our sessions, I would like to remind everyone that you can post your questions in the chat box. All questions shall be addressed at the end of the webinar. Now, I would like to invite our next speaker, Dr. Ramachandran Shaji, who will be guiding us through an insightful session on new molecular diagnosis methods on beta thalassemia. Sir, please.
Can you see my slides?
Yes, sir, we can see your slides.
So I'm going to talk to you about the new methods for the molecular diagnosis of beta thalassemias. And as most of you know, we have been working on molecular diagnosis for thalassemias for several years. And the beginning of my talk, I will describe some of the older methods. Then I will tell in the remaining half of the talk the new methods that we have established in collaboration with one company in South Korea. And we're very excited to share the details of the new method. We find that this method is extremely useful, fast, and it can be very nicely used for large number of samples, especially for population screening. And as the previous speaker has given a lot of details about thalassemia and the molecular basis, I'm not going into details there. Just telling you briefly that the thalassemia is two major types of alpha thalassemia and beta thalassemia. I'm going to talk about beta thalassemia and its molecular diagnosis. And it's also important to realize that when you do molecular diagnosis of beta thalassemias, there can be co-inheritance of delta beta thalassemia and HPFH. And we can't ignore these conditions because they can come in compound heterozygous state with beta thalassemia and can show a phenotype of homozygous beta thalassemia. And molecular diagnosis to distinguish beta thalassemia and delta beta thalassemia is important when we do prenatal diagnosis. And I will go through the details of the methods available for distinguishing beta thalassemia from delta beta thalassemia. And as you know that the mutations in beta globin can be of several types of beta plus, beta zero, it can be anywhere in the gene. And depending on the location and the consequence of the mutations, these mutations are categorized as beta plus or beta 0. And it is, if you look at it particularly compared to other diseases, including alpha thalassemia, the most of the mutations that are associated with beta thalassemia are point mutations, and more than 300 point mutations have been described. And so therefore, the methods are tailored to detect point mutations first, and then look for the rare deletions that occur in several populations. In our population, we have the 619 base pair deletion, and which is very common in Sindhis and Gujaratis. And I'm not going into details of the molecular pathology of beta thalassemia. It occurs because of the excess alpha globins precipitated in the erythroid progenitors, which subsequently cause ineffective erythropoiesis. This spectrum of beta thalassemia mutations in the Indian population, and our study and other studies have shown that there are several types of beta thalassemia mutations are present. Fortunately, there are 6 to 8 mutations are present in more than 85% of patients. Therefore, I said fortunately because we could tailor the methods to detect these common mutations first, and then use the methods to detect the rare mutations. As Dr. Seema said, the most of the time, it is important that we have to have a CPC analysis to look for the MCV levels. And there are very specific MCV levels which could be looked at to say whether the individual can have thalassemia or not. And 78 is a cutoff that we practice. In some places, many centers use 80 as a cutoff. We are quite comfortable to use 78. When less than 78 is used, then beta thal carrier is suspected. Then we do HPLC analysis and see whether they have any one of the different types of thalassemias, including heterozygous beta thalassemia, homozygous beta thalassemia, HBE beta thalassemia, HBS beta thalassemia. And HPLC can clearly separate out the different categories and tell us whether the individual has heterozygous beta thalassemia, which is a carrier state, or homozygous, or different combinations of thalassemia with sickles and hemoglobin variants. So although HPLC and CPC can help in the diagnosis of most of the cases, molecular diagnosis is important in a lab, especially for prenatal diagnosis. And prenatal diagnosis cannot be performed with HPLC or CBC analysis, as you know. In addition to that, many a time we get patients who are transfused coming without parents. And in transfused cases, we cannot do HPLC. We have to do molecular diagnosis. And sometimes the clinically genotype-phenotype correlation is required. And it is absolutely important, especially when you have patients with homozygous.
Sorry for the inconvenience. I think Dr. Shaji got disconnected. We'll wait for him to join again.
Recording in progress.
Yeah, so till the time he is preparing, so Dr. Ekta, we can discuss few things like related to if there are any questions. So
Um, Yes, also I would like the participants to put on some questions on the chat box. So whatever queries you have, we can solve it now or
yeah,
anything later.
till the time he rejoins.
Yes, ma'am. So, ma'am, I have one question for you.
Yeah.
As homozygous, suppose both parents are sickle trait, what is your take on that? Since homozygous sickles are sometimes not very, I think Dr. Shaji has joined. So,
Hmm.
sir, you can continue. Yes, sir.
So, I'm so sorry.
No.
Something happened with the
Yes,
connection.
sir.
So I was telling the importance of doing molecular diagnosis. Then, in addition to, I think this is where we lost the connection. You may get a patient with homozygous HPFH, and it is important to differentiate homozygous HPFH or compound heterozygous for beta thalassemia and HPFH from homozygous beta thalassemia. So genotyping becomes important before taking a decision on the PND for the next child. Then population screening, in many cases for the newborn babies, it is important that we have to apply uh, genetic diagnosis because of the interfering hemoglobin F levels. And these are some of the common methods which are used for molecular diagnosis. And we are using reverse dot plot for a long time. It's a good method. You can see heterozygous and homozygous cases very nicely. And there is arms which using allele specific primers for detection of 619 base pair deletion. Gap PCR can be applied for. And these methods can detect 80 to 92% of beta thalassemia cases. However, in remaining cases, we have to do Sanger sequencing by amplifying the entire beta globin and then doing PCR and DNA sequencing analysis. And using DNA sequencing, we can identify the mutations there. However, we need very expensive equipment for doing the Sanger sequencing if you want the test to be done immediately. Otherwise, many of the small labs may not be able to afford one DNA sequencer, then samples have to be sent outside, and it may have to wait for a week or two to get the sequencing data. And this is the delta beta thalassemia and HPFH mutations that I was talking about. These are huge deletions, and they increase the hemoglobin F levels. And these methods, which I described in the previous slides, they cannot be used for detecting huge deletions which are associated with the delta beta thalassemia and HPFH. So we devised this method using a capillary electrophoresis where we amplify delta and beta globin genes and G gamma and A gamma globin genes by fluorescently labeled PCR primers, and they are analyzed using a capillary electrophoresis, which is a sequencing machine, and fragment analysis, and the peak heights were calculated, and then we could successfully find out whether the patient has got delta and beta globin genes are deleted or not. And we did large number of cases, more than 10 years, we have been using this method for accurate diagnosis of delta beta thalassemia and HPFH. And in addition to that, to identify the breakpoints, we also do MLPA, and using this, we can identify whether we can detect the breakpoints where it starts and where it ends. This is a heterozygous carrier case with a A gamma delta beta deletion inversion. You can see here the half the height showing that the patient, the individual has delta beta deletion in the heterozygous state. There's another mutation which is also in the heterozygous state. And almost all cases of delta beta thalassemia and HPFH, we do this method, and only for finding on the breakpoints, we do relatively more expensive MLPA. Now I'm going to talk to you about the Novoplex beta thalassemia assay, which we developed in collaboration with CGene. And here we chose 13 mutations. Initially, we planned to do for 14 mutations, and for technical reason, one of the mutations dropped out. These are 13 mutations which are present in very high frequency in the Indian population. And these mutations constitute more than 95% of patients with beta thalassemia in our country. And this method works with a lot of their patented methods, techniques. Different steps have got different techniques. And the first step, they use this dual priming oligonucleotide for specifically amplifying the region of interest. And they have a lot of kits for detecting pathogens for different conditions. And they I visited this company, and they have excellent platforms, equipment, and these kits for different microbial set of microbial organisms which cause different diseases. And this is very specifically designed primers which involve the first priming and the second priming to make sure that they get very specific bands, and these look much better than the non-specific bands which usually obtained using conventional primers there. And in addition to that, they have in their next step what they use a method called TOC, that is a little complex name here for this method. And what they do is when the DPO primer gets extended, a probe-like sequence that sits on the primer's extension way, like Tagman probe, where the tag is released from the exonuclease activity of the primer, and this released tag will be caught by a catcher. So then this here it's called a pitcher. From here, what is cleaved is caught by the catcher. And subsequently, what happens here is this tag sequence is extended. And when it extends, the reporter and quencher, which were in proximity in the catcher, they will get separated and the fluorescence will come out. And this will be detected by a real-time PCR machine. And this is a method which they developed for melt curve analysis. And after this is made, and they were analyzed by the melt curve analysis in the real-time PCR, and its melting temperature is calculatable. An advantage of this TOC method is that designing the specific nucleotide here where the cleavage occurs, the mutant specific and wild type specific sequences can be detected. And you can see here, the mutant one will cleave properly from here, and when the wild type sequence, this will not cleave properly from here, and therefore it will not be extended, and the sequence, the reporter will be in proximity with the quencher, and the fluorescence will not be released from here. And in addition to that, to detect multiple targets simultaneously by to develop a multiplex method, they have this strategy called CMTA, where they look at in one channel of the real-time PCR machine, they look at the melt curves of the different targets which are clean. Say, for example, if the melting temperature that of the first target they analyze is on 70 degrees centigrade, in showing the melt curve like this, they could have another mutation where the picture and the tags were designed to detect the second mutation can come with a TM of 65 degrees centigrade in the same fluorescence channel of the PCR machine. So like that, they can have up to 4 different PCR products could be analyzed in one fluorescence channel. And when it goes like this, because the PCR machine, like wire PCR machine, has got 5 channels, each channel 3 targets are seen, then 15 multiplex reaction, they could do it in one run. Because the real-time PCR machine, wire PCR machine can give the data from 5 different channels simultaneously, and each channel, 3 different targets are analyzed, and 3 targets are distinguished from their melting temperature after the melt curve analysis there. And this is it comes as tube A and the tube B, and the tube A has got these combinations. So for the 13 mutations, there is wild type oligos and there is mutant oligos. They are separated in this tube, and they were aliquoted. And then we keep in the A tube, the FAM channel will detect these sequences, hex will detect these sequences, cal 630, 610 will detect these sequences, quasar 670 this one, and quasar 705 this. And B tube also has these combinations here. When how it works is that blood sample can be directly taken and it can be processed for 30 minutes, direct lysis, no DNA extraction, and set it up in a real-time PCR machine, maximum 1 hour to aliquate direct blood sample, lyse the blood sample kept in the and they aliquated into the real-time PCR plates, and then tube A, tube B aliquates are added, and 4 hours of machine run the real-time and data interpretation using their software is only 30 minutes, and 36 to 48 samples can be processed simultaneously. It's a real time saver, and the data can be interpreted using a software provided with the machine. And you can see here how nicely the IBS15 G2C mutation homozygous state was detected here in this particular. This is the data coming from one particular patient here. The patient was IBS15 homozygous, and you can see here the wild type peak of the IBS15 G2C, that is wild type. IBS15 G2C is missing, and hex fluorescent signal showing IBS15 homozygous here. So like that, you can see here that codon 15 G2A, a frameshift 41, 42 mutations could be detected here. And this is a very easy way of detecting the mutations very accurately. And this takes 30 minutes for blood sample lysis and 4.5 hours running the PCR machine, 30 minutes to data interpretation, and 36 to 40 samples at a time. And there's the different conditions that we could see the mutations very.
I think the
cases so far. And we have very good experience using this method, and we were involved in population screening for Orisa, sickle cell disease and beta thalassemia cases, and this method was used for population screening, and also for prenatal diagnosis of the samples, severe samples collected from Orisa. Till today, we didn't face any misdiagnosis at all using this kit. Okay, I'll stop here. Thank you for your attention.
Thank you for your insightful and engaging presentation, sir. I learned a lot and had a great time listening to the newer and the older traditional methods of thalassemia diagnosis. I loved how you explained things. It really helped me understand better. Looking forward to hearing more from you. Thank you so much again, sir.
Thank you.
Yeah, must congratulate on, such a cost-effective and, time also. So, and I'm happy to know that there are no false negative, but any false positives?
No, we did not have such issues at all here. Yeah. But when the kit, when it is giving to us, we do the batch validation. So we always run the positive controls runs in the first time. If the kit is showing some problem, we'll inform them when they will remake and send it. So to answer your question, after validation, we don't face problem for 1 year.
Okay. So other than that, population is screening you are using in your lab also?
Yes. Okay. And this kit is available for everyone. It's a catalog product in CG.
Okay. So they have to contact the lab CG.
Yeah, you can write to me. I can connect you with the in case if you face problems with contacting the people.
Yeah. Thank you.
Okay.
Yeah. Wonderful lecture, quite informative, and so many insights.
Okay, thank you so much.
So before we go to the next presentation, I would just like the audience to write their questions in the chat box, which will be answered at the end of the webinar. I'll be taking two very interesting cases, and it will be a quick one. Okay, so this is a 9-year-old male. He was symptomatic from 3 years of age, requiring intermittent transfusions, and hepatosplenomegaly was present. Hemoglobin was 6.7 gram percent. MCV was 69 femtoliter. On HPLC, HbA2 was 4.8% and HbF was 3.5%. So parent CBC and HPLC was done, where we can see that the father had an MCV of 69, A2 of 4.9, while the mother's MCV and hemoglobin were totally normal, with HbA2 and HbF also within the normal range. So only the father showed some abnormality in the HPLC. When it is 4.9 HbA2 with reduced MCV, we call this beta thalassemia trait. So upon initial assessment, what did we see? We saw that the father was heterozygous for beta thalassemia. The mother had normal HPLC and CBC, while the proband was showing HbA2 of 4.8 with HbF of 3.5. This combination, when present, we usually suspect heterozygous beta thalassemia with alpha multiplication. But unless a molecular diagnosis is done, we cannot really confirm it. So for the proband, we did the molecular diagnosis. So based on the initial presumptive diagnosis of heterozygous beta thalassemia with alpha multiplication, we went and did a HBB gene sequencing to look for any point mutation within the beta globin gene. So as Dr. Shaji has already mentioned, that when we have any heterozygous beta thalassemia, first thing to do is do a look for point mutation within the beta globin gene, since the point mutations are more common in the beta gene. While to screen for alpha multiplications, we had to screen alpha 1 and alpha 2 genes for the alpha multiplication. So as already mentioned, the mutations most common in HBB gene is the point mutation or the missense mutations. So as you can see, if the normal DNA sequence is AGTCGA, a variation in C2A is called the point mutation. The CGA will code for arginine, while when a point mutation happens and AGA happens, this AGA will code for glycine or some other gene. some other amino acid. So now we did a beta globin gene sequencing for the patient to look for the point mutation which was responsible for the A2 of 4.5, and we found a very common point mutation which is a very common mutation in the Indian population. This is known as the IVS15G2C, present in the intron 1 of the beta globin gene. Now, to look for multiplications in the alpha globin gene, we have to do to look for multiplications. We have to look for alpha MLP, that is a multiplex ligation dependent probe amplifications. Okay, so this is how an MLPA looks like. There are multiple probes which go and bind to alpha 1 and alpha 2 gene. Apart from that, there are there are probes which go and bind to the adjacent genes also in the chromosome 16p 13.3, where the alpha globin genes along with the alpha globin cluster is located. Okay, so if you can see, there are LUX7L, ITFG3, Exin1, Decker2, Polar3K. So these are the adjacent genes which are present in the alpha globin gene cluster, and the probes in MLPA also go and bind to these genes. So this is a normal MLPA where we expect that all the probes should lie in the ratio of 1. Okay. Now, this is how our patient's MLPA looked like. So we see that all the probes were above 1. It was around 1.5. And these are the alpha probes which are even higher, but other probes are all above 1. So looking at this, what we thought was that all the probes are above 1. Whatever the MLPA can, within the limitation of MLPA. But what if there was a multiplication of chromosome 16p beyond these probes? So what we did is we did an NGS, and in NGS we did a whole exome sequencing which could detect both point mutations as well as the copy number variations, and we saw that there was a duplication of 7.3 MB in chromosome 16, and this duplication extended from 16p 13.3 to 16q 22.1. So usually what happens is this alpha globin cluster lies in chromosome 16p 13.3. And when I reviewed the literature, I saw there are a few cases, around 7 to 8 published literature, which is showing larger duplications beyond 16p 13.3, that is beyond the alpha globin gene cluster. The most common duplication that happens in the alpha globin cluster is the alpha NT 3.7 and NT 4.2, which is only the duplication of A1 and A2, not beyond that. The published literatures which saw beyond that was around 120 kb, 159 kb, 204, 188, and 282 kb duplication. But in our case, it was a novel one because we found a duplication of 70.3 MB. So it was quite large. So now we did the molecular workup of the parents, because as we have seen that the father was heterobeta, the mother's HPLC looked normal. So we just wanted to see where from this duplication had come. So the father's HPLC showed 4.9 A2 and it was in heterozygous beta thalassemia. Mother's HPLC was totally normal. Sanger sequencing showed that the father was heterozygous for the same mutation, which was also seen in the proband. And mother's HBB gene sequencing showed no mutation was detected. Alpha MLPA of the parents was done, and as you can see, all the probes were in the ratio of 1, both in the mother and the father. So we concluded that there was no duplication in either of the parent. So now the final diagnosis was heterozygous beta thalassemia with segmental duplication of chromosome 16p, which was a de novo mutation and not inherited from either of the parent. So the take-home points is thal intermedia resulting from heterozygous beta thalassemia and alpha gene multiplication isn't very uncommon, but it is often missed since HPLC typically reveals only subtle indications, usually a slight elevation in HbF percentage along with HbA2 increased. This highlights the significance of screening for alpha globin gene copy number alterations whenever symptoms manifest in a heterozygous beta thalassemia carrier. Now, other thing is that isolated alpha multiplication have no abnormality in HPLC. So if a patient, either of the parents would have carried this multiplication also, the HPLC would have been normal. So only when multiplication is present along with an heterozygous beta thalassemia, the HbF percentage increases. Chromosomal 16 segmental duplication spanning the alpha globin genes is a rare cause of alpha multiplication. Only 9 studies are published till date, duplication size of 120 to 300 kb. And our case is a novel one where the duplication size was more than 70 MB. So the point to ponder here was when one parent is beta thal trait and the other is normal, it is not advised to go for a prenatal testing as already mentioned by Dr. Seema. Now, but should we consider alpha globin gene studies in such cases? This remains an open debate because only alpha globin multiplication, as I have mentioned, will not show any abnormality in HPLC. So there is a possibility that the child may be born with beta thalassemia trait and alpha multiplication, which will lead to thalassemia intermedia phenotype. Now, I'll go to the second case, an 11-year-old male child presenting with anemia and periodic transfusion requirement. On examination, splenomegaly was seen, and on HPLC, it was reported as normal elsewhere. So this was the HPLC of the child, where A2 was 1.4, F was 0.7, and there was a small 4.3% in the sickle window. But the report was given as normal hemoglobin electrophoretic pattern. The MCV was 68, hemoglobin was 7, the patient was on intermittent transfusion. So definitely it is very important that we should not report this as normal. A2 of 1.4 A2 is really low, and any subtle peak in any of the windows is important to screen by molecular because there could be some hidden hemoglobinopathies there. The parent CBC and HPLC showed that the MCV for both mother and the father was normal, mother was slightly reduced, A2 was normal, and there was no additional peak in either of the parents as seen in the HPLC of the child, which was 4.3% in the sickle window. Now, MLPA was done as the A2 level was really low. So the first thing that we will think of in this case will be some kind of alpha thalassemia. So the alpha thalassemias in the first thing, molecular diagnosis is, if we go by stepwise approach, the first thing is to do MLPA in the alpha MLPA to look for deletions in the alpha gene. So we did the alpha MLPA, and similarly in the other case where we saw that all the probes attaching to the alpha globin cluster as well as to the nearby adjacent genes were all multiplicated. The opposite we see here is all deleted. Okay, so 0.5 means heterozygous deletion of all the probes, including the alpha globin gene cluster. Now, so this will lead to 2 gene deletions. Okay, one alpha and one alpha 2, one alpha 1 and one alpha 2 from one allele will be deleted. But the other 2 alpha genes in the other allele is absolutely normal. Now, only 2 alpha gene deletion do not lead to such phenotype. So we need to see what was the what led to the phenotype. Plus, there was a 4.3% peak in the sickle window. So we went and did alpha 1 and alpha 2 gene sequencing to look for any abnormality within that. And we found a mutation, heterozygous mutation called hemoglobin Evanston. Hemoglobin Evanston is a mutation in exon 1 of the alpha 1 gene. Now, 2 alpha globin deletion with 1 alpha globin mutation leads to an HBH-like phenotype. Okay. Now, in alpha globin gene cluster, if I'll go through it, there is alpha 1, alpha 2, alpha 1, and then there is zeta 1, zeta 2, HS40. So this is the alpha globin gene cluster. Normally, the deletions, the most common deletions, which are the alpha 3.7 and alpha 4.2, will only delete a part of alpha 1 and alpha 2. Then there are other deletions called Thai, Med, Phil, 20.5, Med 1, Cia. So all these will also delete alpha 1 and alpha 2 along with the other genes in the alpha globin gene cluster. But these deletions do not extend beyond the alpha globin gene cluster. That is, it will not extend to LUX7L and it will not extend to NPRL3. Okay. But in our case, where we saw that it also extended to Lux7L, and even beyond that, on the left also it extended to Pol R3K. So we thought, could it be monosomy 16p? The same thing. We thought that that was a limitation of the alpha MLPA. What if there was deletion beyond that? So we went and did a whole exome sequencing. In whole exome sequencing, we definitely found the heterozygous hemoglobin Evanston in alpha-1 gene. Plus, we found a heterozygous deletion of a large segment of chromosome 16p. And this segment was around 650 kb deletion. And approximately 43 coding genes were deleted. When we did the Sanger sequencing for father and the mother, we saw that the father was absolutely normal and the hemoglobin Evanston was present in the mother. So the heterozygous Evanston was inherited from the mother. While when we did the MLPA for both father and mother, we saw that both MLPA were normal. So again, the heterozygous large segmental deletion of 650 kb was actually a de novo event. So 2-gene deletion with 1 point mutation is an HBH-like disease. So this is known as an HBH disease with ATR16 syndrome. ATR16 syndrome is a de novo constitutional deletion monosomy of 16p 13.3, okay, and a hemoglobin Evanston. Now, hemoglobin Evanston, the mother had heterozygous Evanston, but showed no additional peak in S window. So that was very curious to us because the same Evanston, when present in the child, a 4.3% of the peak was seen in the S window, but the same peak was not observed in the mother. So when I went through and read the literature, we found that hemoglobin Evanston is not visible on HPLC when present alone in heterozygous state. If present with one alpha gene deletion, about 2% of the hemoglobin Evanston will be present. If present with 2 alpha gene deletions, like in our proband, about 2 to 10% of the hemoglobin Evanston will present on HPLC on the sickle window. The ATR16 syndrome is extremely rare genetic disorder. Large deletion of genetic material on chromosome 16p from band 13.3 to terminus of the chromosome can be deleted. Now, depending upon the size of the deletion, multiple genes are lost. If the deletion is more than 1 MB, it can cause to intellectual disability, which can range from mild to severe along with alpha thalassemia. And if the deletions are less than 1 MB, the patients can only present with alpha thalassemia and there will be no other intellectual disability or any other mental retardation like phenomenon. Now, this occurs as a spontaneous de novo event, even with no previous family history or in parents with a balanced chromosomal translocation that is inherited in an unbalanced manner. So these are the different literature reviews which shows a large alpha globin deletion in the chromosome 16p. So we see that there are deletions up to 2000 kb also. So different. So when we see this, the ones which are empty boxes are the ones which show less than 1 MB deletion, and therefore they do not present with any mental retardation phenotype, but they will only present with alpha thalassemia. While the ones which are more than 1 MB will show also alpha thalassemia plus mental retardation. So the take-home point is minor peak seen in HPLC should not be ignored. It always means something. Normal family HPLC screen also do not supersede the clinical suspicion. So when it is very clinically, the clinician is very much suspicious of a thalassemia. It is very important that we go deeper and try to find out a molecular diagnosis. Thank you so much.
So nice cases, Dr. Ekta.
Thank you, ma'am.
Just wanted to ask, both were de novo.
Yes, ma'am. Both were de novo because we had screened all the molecular testing were done on both the parents, and it was de novo in both cases.
Yeah, so that much limitation, I think clinically one has to tell that when one partner is a carrier and the other is normal. So when we say that we don't do, so of course, in any prenatal, this is what we say, that the de novo things can do happen, and no one can predict. So this much limitation has to be discussed whenever we are doing prenatal diagnosis for whatever reason.
And that is
So
where genetic counseling
very
becomes very
interesting
important.
cases and eye openers that, and re-emphasizing the fact that whatever you do, there can be a miss cases, but yeah, these are rare cases, and nicely worked. So congratulations on presenting with two nice cases.
Thank you,
So
ma'am. Thank you.
yeah,
Very nice,
great
very
learning,
nice,
great learning. Yeah.
Thank
very good, very nice.
Thank you, sir. So, ma'am and sir, we have a few questions here. So, I'll put the question. So the first question is, hemoglobin F of 19.9%, a 26-year male with hemoglobin F of 19.9%, hemoglobin 13.8, and MCV of 78 femtoliters. Now, this be reported as heterozygous HPFH or heterozygous delta beta thalassemia? Sir, if you can answer this.
Yeah, so from our experience, it's most likely heterozygous HPFH. But however, you can see whether there is any affected child with severe anemia or not. So you can correlate that also. And most likely it is heterozygous HPFH. But simple PCR, like gene dosage PCRs that we do, we can find out whether what is what here.
Yes, sir. Yes, sir. So we need to look at MCV as well as the percentage of HbF, and depending on that, we can give. But obviously, the final diagnosis will be given by molecular.
Yeah, 78.4, most likely HPFH.
Yes.
Yeah,
So,
persistent.
yes, sir. So there is one more question. Best molecular method to detect thalassemia. Sir, would you like to answer this?
Yeah, so it depends on whether you want to do a large number screening or one sample per month or one sample per week. If you have only one sample per week or one sample per month, do Sanger sequencing. And don't invest your time and effort to have your common mutation method at all. But centers like us, we get a lot of patients, 10 samples per day, and per week will become 40, 50 samples. Sanger sequencing is a, it can take away a lot of time and will be expensive. So population screening, I really do not suggest Sanger sequencing at all. Better to use the Novoplex method from Seegene, and which is good. I'm not, I'm not working for Seegene, and it's our experience that it works really well.
Sir, I have a question for you. Is there a separate equipment for the Seegene assay, or can we run the assay in the usual BioRed or Thermo Fisher real-time PCR machines?
You have to buy this BioRed real-time PCR machine, and depending on the number of samples that you're going to screen, Seegene usually gives the machine free. The cost per run is only 600 rupees per sample, which we calculate including GST.
You need to extract the nucleic acid. The whole blood can be.
Yeah. We save on that, but you can negotiate with the company to have a free machine, because most places buying a capital investment to buy an equipment is challenging. Yeah.
Okay. And I have one question for Dr. Seema as well. Ma'am, suppose both parents are sickle trait and they already have a child who is homozygous sickle but transfusion independent and leading a normal life. And should this couple plan for a prenatal diagnosis in the next pregnancy, or is it okay to just let it be?
Yeah, actually, most of the time for the prenatal, they would come to us by the parents' choice only, because the quality of life is affected. It's not only transfusion, it's also the painful crisis. We have seen, we worked in thalassemia ward, sickle cell anemia ward, and every 2-3 months, few patients would come with sickle cell crisis. They were in great pain, and so the quality of life. So many of them would come to requesting, because they don't want this kind of baby, and most of them are Africans, tribals who would request. So it's justified. But yeah, it's the parents' choice.
Yes. Okay. One more question for Dr. Shaji. So we get a lot of cases, especially from West Bengal, who are homozygous for HBE, but they do present with symptoms with anemia and transfusion requirement. So, sir, what else should we screen in those cases?
So are they older patients or young patients?
So they are in the second or the third decades.
So 30, 40 years. That's
20,
what you mean.
yes.
Yeah, so we have a lot of cases like that, but they are relatively smaller. Some 10-20% of homozygous E presents with symptomatic anemia. But if you look at that, do just see whether the patient has got severe splenomegaly and they have severe anemia, or the anemia can be managed with occasional transfusions. Just leave them alone. And we try to look at alpha thalassemia, alpha triplications. We don't see any variations at all. But Unipath, which has sequencer, can take some 50 samples and do a sequencing and give us the information. So we can't, so
Yes.
you can look at that. But
I
all our
recently-
efforts, we could
Yes,
not
I
find.
recently found one case which was homozygous E with alpha triplication. So that could explain
Okay.
the severity.
We have seen such a case 2 months back, homozygous E with the triplicate alpha. But when we large number of samples when we screened, very rarely we
Yes,
saw.
mostly they are usually normal, sir. So we need to actually look at the modifiers, other genes modifiers.
Yeah.
We don't have any more questions, sir and ma'am. So it was really a very insightful webinar. We all learned a lot, and I'm sure the audience also enjoyed this webinar. So with this, I think we should end this webinar, and we'll be hoping for more of the talks from both of you in the near future.
Thank you,
Thank
Dr.
you.
Ekta.
Thank you, ma'am. Thank you so much.